shot I saw in Myanmar, the volunteering services for blood donation and ambulance. Van Ecker in 2004 reviewed 36 children, similar age at diagnosis 19 months, 17% were less than 1 year, 56% male, and the reason it had come to attention tended to be to do with the anemia, so pallor and tiredness. The median hemoglobin was 44, absolute reticulocyte count 0, 47% were neutropenic, and 64% had platelets more than 400. 50% had a preceding viral illness, but the serology was negative. The 26 out of the 36 received a red cell transfusion, and another 10 patients recovered without any treatment at all. One patient received 2 weeks of prednisone and oxymethylone, and it looked like they recovered with regardless of the treatment, so the medications were discontinued. And at follow-up, there was no signs of recurrence or evolution. So this is a summary from Van Ecker of the TEC cases. From here, we can see, on this side, we can see the normal MCVs, reports of low neutrophils, the age at diagnosis, and the hemoglobins that we're seeing. So typically, there'll be anemia of 1 to 2 months duration, followed by complete recovery. And at presentation, there's reports of 5 to 10% being in the recovery phase, so seeing a reticulocytosis. And the Feen contrast, the Sherrick reported 25%. The other study I reported also showed 20%. There's no evidence that steroids affect the time to recovery. And we would you can often defer transfusion unless there's signs of cardiorespiratory symptoms or significant fatigue. So this is in Lay Lake, which is one of the local fishermen fishing. So diamond black fat anemia was the first report of red cell aplasia in infancy was by Joseph in 1936. The 4 cases were presented and refined as a clinical ST by Diamond and black fat in 1938. Diamond black fat anemia is rare, with 5 to 10 cases per million live births, typically presenting. And being paediatric trained, it's always really important to take a full comprehensive history from our patients. This patient was called patient TB. So at the time that she was really sort of presented to us, she was a 17-year-old female. Her birth history, she was born by a cesarean section at term. She was a breech presentation, and she was actually the twin number 2. She came out at a birth weight of 2,400 grams. Her medical history was quite extensive for one of our adolescents presenting. So she had a strong history of depression and was being seen by a psychologist at the time. She was morbidly obese. She had an elevated baseline insulin with a BMI greater than 35. She'd been diagnosed by the GP with polycystic ovarian syndrome. And interestingly, had a diagnosis also made of complex regional pain syndrome of just a single digit, her right thumb, and it was thought to be after the removal of the Freudian ganglion in March 2011. Turned out not to actually be a ganglion, but just some thickening of the ligaments. So in terms of the family history for the patient, we can see she's there in the blue dosh, coloured in. She has a twin sister, slightly older than her, being twin 1, and she's well. And she had a 19-year-old brother who was also well. Her father died at the age of 40. It was actually a patient at the William Angus Hospital at the time, was admitted with what we know to be severe sepsis, and actually the thought was he died of a pulmonary embolus during that admission. He had had a previous PE at the age of 20. Patient TV's mother has been quite well with no issues. So the first contact with haematology actually was to Professor Paul Monagle when a referral came from the coroner in 2001 at the death of TV's father. At the time, she had a thrombophilic workup, which, as you can see there, is all normal. From the testing they did, they were unable to identify an inheritable cause of thrombosis. So extensive education was done with both the patient, she was 4 at the time, but also mainly her mother in terms of what risk factors to worry about in the future and what things to avoid. She was then reviewed in 2008, at which time TB was 11. The risks and issues were reiterated to her family, particularly about the oral contraceptive pills, travel, dehydration, and also alcohol and drug use when she was coming into those teenage years. But unfortunately, in October 2013, she presented to the Royal Children's Hospital with a 2-day history of right upper quadrant, right shoulder, and upper back pain. She described the pain as being severe, cramping and pleuritic pain. She had no infective symptoms or any other complaints at this stage. Further history revealed a medication was started 4 to 6 weeks earlier. She was actually started on the oral contraceptive pill by the GP. The notes say that as a treatment for the polycystic ovarian syndrome. Examination, she had a normal heart rate, blood pressure and oxygen saturation. Her weight was 105 kilos, height 168 and a BMI of 37.2. Abdominal examination revealed a tender right upper quadrant with no guarding or rigidity. And she had a tender right upper back and shoulder, but full range of movement. Normal ECG. Her blood investigations are all practically normal here, except for an elevated CRP of 168. And further testing, full blood count was also normal, except for a mildly elevated white cell count with a neutrophilia, very mild. Interestingly, her coags here at the bottom of when she was actually presented to emergency. She had an INR, which was slightly above normal at 1.3, an APPP of 34, and a fibrinogen of 0.6. That would be low. Normal age group for this, or target for this group would be 1.5 to 4.3. I'll come back to the low fibrinogen in a little bit. So patient TV went on to have some investigation. She had a normal abdominal ultrasound, although they did describe it was technically very difficult given her weight. She had a normal lower limb Doppler ultrasound. Then she went on to have a VQ scan. The VQ scan showed a combined ventilation and perfusion abnormality in the right base, of which the significance they weren't sure at the time. However, they did say there was a well-ventilated perfusion defect in the left lateral basal segment, which as per our nuclear med guides, they considered to be a diagnosis of a pulmonary embolism. The acute management for this patient consisted really of 2 things. Firstly, the commencement of anticoagulation. In emergency, she was started on Clexane and then was subsequently transferred over to warfarin with an INR target of 2 to 3. She also had repeat imaging. We did a repeat VQ scan at 3 months, which showed resolution of that PE at that left basal segment. However, we still had that fixed abnormality in the right base, which they still weren't sure what it was, but thought perhaps an old small pulmonary infarct. So obviously with quite a complex case, with lots of things going on in this patient's medical history, we sort of identified 6 key issues for ongoing management. I'll touch on a few of them briefly. So the first one, as I've said, is the anticoagulation. So we had her on warfarin with an INR target of 2 to 3. The second main issue for this patient was contraception. So at the time that she presented to us, she was 16 and a half and had obviously been commenced on the oral contraceptive pill by the GP. She had concerns that, at her age, the other girls at school were being started on the pill and wanted an option. But also the GP had advised that we, were treating her polycystic ovarian syndrome, and so she was keen for some treatment for that. Obviously, we weren't keen to put her on anything like what she was on before, so we looked at sort of simple barrier methods, education for the patient, but also progesterone-only options. Then in the second point, which is also linked to that, was about her menstruation. So at the time that she was seen with us, she was actually oligomenorrhea, and we made a referral to the gynae team. The gynae team have organised for actually to have cyclical progesterone, to have 3 withdrawal bleeds per year to help deal with this. The fourth issue, which is obviously quite a big one, is her weight management. She was referred to the weight management clinic at the Children's Hospital, and her weight is stable 12 months on, so she's still weighing at 105 kilos, but at least she hasn't put on any further weight. The fifth issue we identified was the psychosocial issues. She was clearly very depressed. And the interesting thing about this patient is that, as you can imagine, with her body habitus, she's quite morbidly obese. Her twin sister is like a stick, similar height, but very skinny.
So there's obviously lots of things going on for this patient that's very different from her sister. And obviously she was started on antidepressants and has been formally seen by the psych team at the Children's Hospital. And obviously the last point being education in terms of the risk factors and what things to avoid now that the patient's actually entering adulthood and needs to be responsible for her own care. So I just want to bring you back to those blood tests we had before that I flagged, particularly the fibrinogen. So when she presented, she initially had a fibrinogen of 0.6 and it was repeated in the evening just to get a figure for whether this was correct. And it was indeed correct with a fibrinogen of 0.7, so low. As expected, her thrombotime was elevated this time at 30.7. As you can see, these are the blood tests over a number of months while we've been looking after this patient, and it's showing that she's had consistently low fibrinogen. The red line just indicates what would be the lower limit of normal for us for the fibrinogen. So I want to briefly touch on disorders of fibrinogen. There's predominantly 4 different, classifications or different groups. The first one being dysfibrinogenemia, which is the presence of a dysfunctional fibrinogen molecule, but in normal amounts. The second being hypofibrinogenemia, which is the reduction in circulating level of a normal fibrinogen. The third being a combination of the two, so hypodysfibrinogenemia, in which the inherited fibrinogen is both functionally abnormal and also in low levels in the body. And then there's afibrinogenemia, which is complete lack of circulating fibrinogen. So obviously from the blood results we've got for our patient, she's sitting at number 2 with a hypofibrinogenemia, but clearly we think there's something else going on. So if we look at the dysfibrinogenemia, which at the moment is what we think may be the problem with our patient, there's been about 260 reported cases from a reasonably old group in which they say the majority of the mutations are point missense mutations, which leads to a dysfunctional protein product. As you can see, that 55% of the mutations cause a silent phenotype, i.e. that there's nothing that we can see. 25% are hemorrhagic, 10 to 20% are thrombotic, and then 2% is both thrombotic and hemorrhagic, which would be very difficult to manage. So if we look first at the hemorrhagic variant, so that was about 25%. They're quite a heterogeneous group in terms of how they clinically present. Obviously things like epistaxis, menorrhagia, which can sometimes be a flag for some of our adolescent patients, easy bruising, soft tissue hemorrhaging, post-op bleeding, and the antepartum and postpartum bleeding. Also joint bleed. The thrombotic variant, which we think is where our patient actually sits, accounts for between 10 to 20% of these mutations. However, the most common way they present is actually with a lower limb venous thrombosis, which is actually not the way our patient presented. There have been a few case reports of an arterial thrombus, and there's quite a high rate of pregnancy-related complications. So I know you've all just started to eat, but this was kind of where we thought we'd actually look for some advice from the audience. So we've basically got a patient who has had a first presentation of a PE with a very strong family history of thrombus. We've got documented low levels of fibrinogen, but clearly there's something going on given she's had a clot. So the first question is, what would the duration of everyone's anticoagulation be?
Can I ask some more questions about the fibrinogen?
So did you do a reptilase test? Does one of the registrars who want to talk about the reptilase assay? It could be a question on the, yeah. So